Thanks so much to all three of you for presenting today at our ACT-CTU rounds. The pleasure of being on the committee, the ACT-CTU committee with Amity and David. We've met, so thank you for that. And nice to Terry. I think we've met before as well. So I just want to introduce the three of you. Thanks to Amanda again for organizing. We have here from the University of Calgary, Dr. David Campbell, who's an internal medicine specialist and has done subspecialty training in endocrinology and advanced research training in health services research. And his area of research is in social disparities and the impacts on clinical outcomes of metabolic disease. He has extensive experience using mixed methods and participatory patient-oriented research, and current research program focuses on the development of novel interventions to improve the care and outcomes for socially disadvantaged populations with diabetes, and is, as mentioned, the co-chair of the ACT-CTU from the University of Calgary. And Dr. Amity Quinn is a health economist specializing in policy evaluation and works collaboratively with health system partners. Her research primarily focuses on policies that are designed to improve healthcare access and value for people with complex health and social needs, including physician payment models and insurance benefit design. So her expertise, data analytics and advanced statistical modeling using population level administrative data and policy analyses. And she also currently is the co-chair of the ACT-CTU at University of Calgary. And Terry Saunders Smith is the manager for the Health Policy Trials Unit and has over 14 years experience in coordinating both industry investigator design driven projects. So thank you so much to all of you. I think Terry, do you have your hand up? I'm not sure. There's an emoji. No? Okay. I'm not sure what that is. That's on our end. Okay. Okay. Acting. Anyway, thank you so much. And I'll hand it over to you guys. And we'll leave questions for the end if that works for you.
That sounds great. Thanks for having us. Amity, go ahead. Take it away.
Okay. Good morning, or I guess it's afternoon where you are, enjoying your lunch time. Thanks for coming. Dave, Terry, and I are the Health Policy Trials Unit. Basically, we have some other stuff I'll tell you about soon. We're going to talk to you today about what we're doing and talk about what policy trials are, give some examples and sort of lessons learned and what we do. So next slide. Yeah, first I'll just start with the land acknowledgement. We're in Calgary, located on Treaty 7 territory, and also home to Métis Nation of Alberta Districts 5 and 6. But I know you guys were all in different places from around Canada, and just everyone can take a moment to reflect on the land they are and the importance of land and health. Okay, so I already kind of gave a rundown of this, so I think we can skip this outline. Okay, so what are we? I think you guys are probably more familiar with like what an ACT-CTU is than most people that we talk to, so we don't need to kind of give you a rundown of what ACT is. But we are, I think, different than a sort of classical clinical trials unit where there's a lot of stuff that I think a typical CTU does that's not really relevant for us because we're not testing drugs and devices. But we have lots of other challenges that we're addressing in policy trials. So as the policy trials unit, we're running policy trials, we're helping other groups design them. We can help do analysis and training. And so in terms of like classical CTU type things, we're a new unit and kind of growing and exploring, and we'll learn more about that later. But I think we're kind of developing all the sort of trials unit stuff that we can do. Next slide, please. Okay, so you guys have already been introduced to the three of us. We also work with some other faculty that do sort of health system change kinds of trials, and other kinds of policy trials. We have some other trial coordinators in addition to Terry. We have two postdocs working with us, a number of research assistants. We work with some consultants, and we have an analyst that's working with us at this point. Next slide. Okay, so what is a policy trial? Which I think that's maybe what you guys may be more interested in. So in a policy trial, they're typically like often pragmatic trials and where we're testing social, economic, and healthcare interventions that improve health. So, and then we often try to include some sort of implementation science component to understand why it's working. So this could include things like a healthcare um, a healthcare delivery model change. It could include something like an incentive to buy healthy food. It could include something like how a change in how you pay surgeons. So those would all be kind of like a number of those are sort of at the whole healthcare delivery system level, or something that's like at the government Ministry of Health or health regional health authority kind of level, um, where you're changing maybe how you pay for or regulate prescription drugs, or like the example of the food policy is something that's kind of a outside, or it could be part of a government intervention, or maybe some sort of like community organization type change. But the way that all of these, a common thread of all of these is that they're all at really a system level or an organization level. So they're kind of these big changes that are happening at a broader scale. Next slide, please. Okay. And so how is that different from a clinical trial? Maybe you guys might understand that more than a lot of the other audiences that we talk to. There's a lot of similarities and differences. So next slide, please, Dave. So we like to show this kind of continuum of from sort of explanatory classic clinical trials to the more pragmatic trials. I think the policy trials, again, we do try to do them or conceive of them as pragmatic as possible. And so at these, if we're looking at, I'm not going to read everything on this slide, but thinking about what they're testing, we're more looking at effectiveness in the real world. How do these policies work in the real world compared to efficacy? Like how does a specific drug or device work? We're doing them more to inform decision makers. Um, and then how they're working. Yes, they're often reflecting usual care, or maybe it's not like how care has been delivered so far, but as I mentioned, it's like a broad sort of health system change. So it's sort of like how you would want care to be delivered in the future. Um, and that brings lots of challenges of working in kind of a real world system. Who is included is, I think, one of the most interesting elements of working in this. So we often have as very broad inclusion criteria instead of selective inclusion criteria. So the results can be really more representative of the general population. But a way we do this is often like, how are we recruiting? We're often not thinking of enrolling people and consenting them one by one. We're thinking of how could we use an electronic medical record to flag and then enroll people? How could we do a registry-based trial where we can find everybody who's relevant to receive a certain intervention, or um, other strategies on the trial we're working on right now, or if we implemented something with community pharmacies, they would have the list of people who all get a certain kind of medication or something like that. So, and then how are we doing data collection and finding outcomes? We're almost always trying to use like regularly collected healthcare or social services kind of data that so we don't have to spend either participants' time or like clinicians' time, or like frontline social services staff time to actually collect data. Next slide, please. Okay, So another element of this is that, we are talking about policy trials, and we exist within the Center for Health Policy at the University of Calgary. So when we're thinking about policy, health policy compared to like a clinical trial, when health policy, and it's like, so our goal is to, try to inform policy making, whether that's at the government level or health system level, with as best evidence as we can, and try to encourage prospective research on policies. But as we all know, just from like living in the world and understanding or living within politics that's happening around us, like evidence is not the only thing that informs policy decisions. So how much things cost is always important, and I think we try to include costing analyses in our research. Whether there's, I think the calendar, I think symbolizes like, is there a policy window for this opportunity? Is it relevant at the current time? How is it affecting, different groups of people, um, and how is it affecting whether that's the potential population of people or users of an intervention, or like clinicians or other care providers. And so there's a lot of different kinds of information that go into making policy decisions, and ours is, as much as we want ours to be considered, it's only one piece of the puzzle. So other things are going to be influencing decisions that we can't control. Anyway, next slide, please. Okay. So since this is all happening in the real world, and they're different than sort of regulated, drug and device trials, policy trials often need different kinds or special kinds of support. So it's very complicated to be doing these in the real world. Again, they're not legally required, like testing a drug or device. Can be very challenging to get grant funding, as we all know. And another core element of all of these is to make them relevant to decision makers. Like, we can't often, and because they're at these like system levels, we can't just really come up with an idea and try it out. Like, we need to be engaging with decision makers within these systems as we're developing the ideas likely come from them in some way. And then we need to be engaging with them during the process, and then also in translating the results. And that can take a lot of effort and energy. And sometimes it's a very like long-term relationship development process. And you might need to we need to be just like ready to do a trial when they're ready. And then this eyes on the prize thing is that even when it's something that, we might be interested in, one study or one outcome, always need to be thinking about the outcomes that are relevant to the policymakers and to the population and systems as a whole. And that's what we really need to be focusing on. Next slide, please. Okay, I think I'm turning this over to Dave now to give you a couple like concrete examples of policy trials that we've done.
Awesome. Thanks, Amity. Yeah, I'll take it over from here for a little bit and walk you through two examples of kind of policy trials that we've recently completed to give you a sense of how this shakes out in the real world, kind of as Amity has alluded to, kind of what a policy trial is. Now I'll tell you kind of about a couple specific ones. So the first one is a trial that we call the Food RX trial. And this is a trial that was led by myself and Dana Olstad, who's a public health dietitian here in Calgary. And we just finished this trial in the past couple of weeks. So unfortunately, I don't have results to share with you today because it's still kind of brand new and we're in the analysis process. So, I was hoping that we might have results, but it's still a few weeks out. So quite exciting. We've just completed this trial, and I'll tell you about it. So we randomized over the past few years 594 adults with diabetes who also are experiencing food insecurity. And they randomized to one of these two groups, one of which is a policy intervention. So the usual care group received a healthy food prescription. It was essentially a pamphlet, and I think I have an example to show you kind of what it looked like, about kind of what a healthy food prescription might look like. The second one, the intervention arm, is obviously testing the active ingredient, if you will. And in this case, the hypothesized active ingredient would be that it's not good enough to just give people a handout, but you actually need to make food more affordable for them because they are all experiencing food insecurity. And so we did that by operationalizing a healthy food incentive. So if people bought healthy foods, they received money that they could use to buy their next set of groceries. And the amount was $1.50 per day per household member, which doesn't sound like much, but when you add it up, that's, $10 a week for an individual, $20 a week for a couple, or $40 a week for a family of four, that can be used to buy produce and dairy and other healthy foods. And they were randomized equally between the two intervention arms. And oh, let's see. Yeah. So along the way, we learned a few things with this trial. We learned that it was quite hard to recruit people, and we'd initially intended for primary care clinics to be the ones that would be recruiting participants and screening and referring to us and delivering the prescriptions. And so it was really designed to be a primary care delivered trial. But we had quite a bit of uptake with primary care clinics and primary care networks who wanted to do this, and they deal with food insecurity all the time, and they feel quite frustrated that they don't have anything to offer their patients. So there was lots of enthusiasm about this work. But the practicality of adding this workflow in the primary care landscape was just really difficult, and made even more so by the fact that we actually launched this trial right at the very beginning of COVID. So that was particularly challenging for us. But also, the staff told us that they're just all burned out. They're already, working at their full capacity, and adding anything else on, even if it's going to benefit their patients, is just too much for them to handle. They also had a hard time, they don't routinely screen for food insecurity in many primary care practices. Sometimes they use their kind of own interview-based ways to do that, but they don't have a list of people who are food insecure that they could go and find in their EMR or something like that. And similarly, they didn't always have the values that we needed. We need people with a certain A1C level. We didn't want people whose blood sugars were perfect in the trial, since that was our primary outcome. And so they didn't have all the data that we needed that we thought they would. And so it made recruitment really quite a challenge for a study like this, that we need a large number of people. And ultimately, this resulted in a relatively low yield. So by working with the primary care clinics, we'd only managed to recruit about 100 out of the total 400 people that we needed for our trial. And so that made us kind of go back to the drawing board and think about different ways we could do things. And so we developed two additional pathways to recruit people. And this is a lot of what doing a policy trial is. And I think, as Amity mentioned, that we in some ways we're kind of doing these things on the fly. I think a lot of times, a standard clinical trial is very protocolized, and from the very outset, you have to say exactly what you're going to do. You publish your protocol, and you try not to deviate from that. And while that's the ideal for a policy trial, a lot of the times, because we're doing things in the real world and in people's practices and in people's lives, it necessitates a certain degree of flexibility. And so we did come up with these two additional recruitment pathways, where it wasn't just family doctors that could recruit for our trial, but we reached out to pharmacists and specialist doctors, my colleagues, as well as dietitians, to see if they could do the recruiting for us. And that certainly brought in a number of people to the study, but we ran into the same barriers and challenges there. And so then we said, well, we don't maybe need clinicians or clinical people to do this recruitment for us. How about we advertise it broadly in places where we're likely to encounter people who are eligible for our trial. So we went to food banks in various communities. We advertised in community events. We sent out emails to lists of people that we could get our hands on, and invited people to do their own screening. And this certainly created more work on our end, because it's a lot more to sift through, because we're getting many more people who are not eligible that we had to determine. But certainly opening up these allowed us to reach our enrollment target of 594 people in the study. So the next thing that we ran into issues with was confirming eligibility. So again, in a normal kind of standardized clinical trial, you have to do all of your eligibility assessments before people are randomized, and it's very, standard, fill out this questionnaire, do the blood work. And in trying to do it in a large number of people in a pragmatic way where people are in community, we're not bringing people to our study center. That's another big difference, is that this is people from all over Alberta, and there was not truly a study coordinating center like you'd have in a standard RCT where people come in and you can get all your assessments in one shot. And so we had to, try to get people to answer our questions, and assessing food insecurity was quite challenging. And there's a well-validated measure for assessing food insecurity, but it's not, as I mentioned, not routinely used in clinical practice. So we had to get people to try to ask their patients these questions. And there's lots of them. It's an 18-item questionnaire that's validated to identify food insecurity. And similarly with the lab tests, as I said, initially when we started this trial, we were looking for people with really high blood sugars, because they're the ones who are most impacted by these types of interventions. And so we set a really high threshold for eligibility. And for both of these reasons, we were getting a relatively low yield in terms of people qualifying for our study, and a really slow recruitment. And we were paying lots of money. We were paying for lab tests for people. They were completing data collection, and then they were not eligible. And so we burned through a good chunk of our budget in the early stages, screening ineligible participants. And we kind of realized shortly into the trial that if we kept this up, we'd run out of money and have a trial of 20 people. And so we had to revisit all of our eligibility processes and how we got people into the study. And so we lowered the A1C threshold, so from 8% to 7, eventually to 6.5 in our trial. And we realized and acknowledged that there's a trade-off between our statistical power to get the numbers that we need, and the malleability, or how much we're expecting to be able to change the A1C threshold. And so that was partly actually why we ended up having to increase our sample size from the initially proposed 400 to 600, just to make sure that we had the power we needed. We were able to get access to our electronic data repository to be able to assess people's A1C levels before sending them to the lab. And if they'd had an A1C done in the last month that was at 5.5, then we didn't bother paying for their labs and paying for their time to enroll in or to test for eligibility. So another example of some tweaks that we made along the way. And then the intervention itself also needed some changes too. So to kind of give you a sense of sometimes how messy these policy trials can be, is that we'd initially proposed and thought that we would offer a subsidy for healthy food, so that we would give money to people up front and say, we want you to buy healthy foods. Here's this money. You can spend it on these certain things. But when we finally found a grocery store partner that would work with us, they didn't have a mechanism in place to be able to do that type of work. And so they said that the best they could offer is not that kind of this predetermined list, but they didn't have the capacity to do that, and doing it by manual kind of operations would have cost too much money and time. And the supermarket that we found was willing to implement something like this, but not quite a subsidy model that we anticipated. And what we ended up doing is doing it through their loyalty points, and so people would get loyalty points instead of dollars, and so that was the workaround. And it seemed like it was going to work, and we implemented it, and we didn't pilot test it because it was the study was launching, and shortly the kind of in our essentially run-in phase, the first few weeks, we realized that some participants were not getting the correct subsidy. There wasn't the right amount going onto their card based on their household size or based on what they had spent. And so we had to stop the trial actually after kind of this initial run-in phase, and work with the grocery store partner to resolve all of these operational issues. And then we were able to pilot it and test it and make sure that it was working. We implemented a helpline to help people if they were running into issues redeeming their subsidy. And we implemented these processes, these kind of standardized operating procedures of regular testing of the incentive and auditing to make sure that it was working properly. And so again, kind of a solution that we had to implement on the fly that we hadn't anticipated early on. There are still challenges with the intervention throughout the trial. Even once we solve these technical issues, the incentive is not entirely easy for people to understand, because you earn points that then you can spend rather than the other way around. It was not always straightforward, and so in our helpline, we'd often get people calling and not understanding why or how the subsidy was supposed to work. And that's part of also doing and why we do a pragmatic RCT, that this is really testing the effectiveness and kind of the deployment of this specific policy in people's real lives and whether it changes behavior and changes outcomes in a real life setting rather than an ideal setting where kind of a lot of these things might already be taken care of for them, right? If you think of the way we do drug trials, most of the time people don't have to go to a pharmacy and pick them up and pay for them, but the drugs are given to them in the right packaging, in the right format, and all of those things. So that's really an efficacy design, whereas these types of policies are really real world practical situations. And does this work in people's real life? I'm happy to pause here and see if we have a hand. So
Yes.
happy to take a question. Yeah.
Thank you very much, Amela Mami. I didn't know if I can ask question now.
Sure.
So I have a question here. You are running a pragmatic and you face some challenges, but have you uh, tried in a pilot trial before going to the big trial? Have you tried to see how it does work with the pilot trial?
Yeah, good question. So, we did not initially do that, and that's kind of what I was mentioning is that we hadn't initially done a pilot, and part of that was due to COVID actually put the study back quite a long time. So we were a year behind schedule, and funders and partners were all quite anxious and antsy to get the study going. And so we, under pressure from funders, we started the trial and had these issues. And so, kind of as I mentioned here, we stopped it, and we stopped for 3 months. We resolved it, and then we restarted with kind of a pilot phase where we tested it extensively. So, live and learn. And, in future trials, we certainly will insist on making sure that the intervention's working properly before actually randomizing and enrolling people. But yeah, it was just the nature of what sacrifices that had to happen during COVID, and because we were behind schedule and funders threatening to remove our funding unless the trial started, we did not do a true pilot. So that's something that we are now doing more regularly, I would say.
Another question that I had is regarding registry. So I'm not sure if when you wanted to publish, it still is a trial, it's a trial
Hmm.
that you have involved human participant on that.
Hmm.
Do you think that would not be a problematic during your publication?
No, it's not because I mean you have to track them and you have to actually show all protocol deviations and what dates those were made and all of those things. So that's all required at the time of publication, and we track that in our this is all registered on clinicaltrials.gov, and every time we made a protocol amendment, we had
Okay.
to upload those changes. So that's all still the same. And I would say if we made changes to the protocol halfway through the study, then you get into issues of data validity. But because this was very early on and we hadn't put through half the participants before these changes were made, we're talking this is a 5-year trial and these changes were made in the first 3 months of the trial. So ultimately, the vast majority of participants received a similar intervention. So we'll see what the peer reviewers ultimately say, but that's kind of what we'll say. And we have documentation to show when these changes were made and that they were all early stage changes.
Okay. So maybe I didn't formulate well my question. So it's still for policy trial, we need to register in the
Yes.
register go. Okay.
That's right. Yeah, it's still expected to register and to have all those documentation. It's not that there's no reg oversight in terms of Health Canada or FDA oversight, but it's still expected to be prospectively registered. Most of us still publish our protocols ahead of time so that people and readers can do those types of critical assessments to say whether the regular standards of a trial were followed.
Okay. Thank you very much.
There is also, in addition to clinicaltrials.gov, there's also the American Economic Association has a like social and policy trials registry. So we haven't registered in that database so far, but if you're interested in policy trials, it's like at least an interesting place to go and look. I think it's less, well known, and especially in the health field specifically, I
Yes.
think we're still mostly
Uh,
using clinicaltrials.gov.
I haven't run policy trials, but this is why also I attend the workshop. That thank you very much for putting that. But since that we are seeing lots of politics and policies happen in the healthcare. So I think it's a good timing to move forward this kind of trials I think it's helpful. So yeah, thank you very
Thank
much.
you. Appreciate that.
I have a
So
question before.
yeah, go ahead. Yeah, that's a good time to take a
That's Louis.
question before we
Yes,
move on
Louis
to the next
Pilota.
trial.
Yeah.
Go ahead, please.
Yeah. Hi. Thank you. Listen, I don't, my question is out of ignorance or misunderstanding, but what's policy about this trial? I mean, will it lead to policy change or like basically you're giving, card points to buy food? So
Yeah.
I'm not quite sure why this is called a policy trial. I'm missing something.
Yeah, good question. So it really gets at the issue of how you define policy. We view this as a policy trial because it's something that can be implemented beyond an individual level. So our partners on this trial were the Alberta government. We partnered with the Ministry of Community and Social Services. And we partnered with Alberta Blue Cross, which is the largest health insurer in the province. And so they were quite interested in the results of this trial and funding this. They partially funded this trial to see whether this would be a policy that they could implement, a benefit they could add to their social programs, right? So if it helps show that we improve food insecurity, that we improve diet quality, that we improve people's quality of life, this is implementable at a policy level. So this is something that would be operationalized through people's existing health benefits. So there's a clear policy implementation lens here, and that's why, as Amity said at the beginning, we do these trials alongside usually an implementation study, and so we call them hybrid study design. So we actually study how did it work, why did it work, what were the pain points, what would need to be changed in order for this to become government policy. And so that's how we define policy, as an intervention that can be implemented at scale, not a drug given to an individual or a device given to an individual, but a policy. And there's lots of different policies, macro level policies, micro level policies, and this would be considered kind of a meso level policy, something that can be implemented by somebody like the health insurer to improve access to food and determine whether it works and ultimately enable them to make decisions about how they fund these types of programs. I hope that helps.
Thanks a lot. I think I'm running a policy trial without knowing, so I'm going to reach out to you.
Yeah, absolutely. And I think you're absolutely right, Louise. Many people are doing policy trials and don't know they are, and don't know that we've got a community of people that are trying to do these types of things. So I think that the more we talk about them, the better. That kind of to say that lots of people are doing this type of work, and there's certain considerations that are a little bit different. And I think if we can all learn and grow together, and I think that's part of why we were excited to see that ACT was happy, was wanting to have a policy trials unit to develop a bit of a community of practice in this space, because I think you're right. Many of us are doing policy trials without really knowing it and without knowing what other people have done. And so I think we can learn from each other. So yeah, please reach out. We'd love to discuss. Maybe I'll tell you about the next policy trial here, just to kind of give you a sense of, so as I said, kind of this Food RX trial was kind of at the meso level. So at the kind of who would implement that would be not truly the government. I want to tell you about the a more macro level policy trial, and this is called the Access trial, and it's got a very long name. I won't read it to you, but you can read it there. And this is a completed policy trial. So we published this trial a couple of years ago, and I want to take you through. I can take you through some of the design and the results of this trial as well as some of our learning. So this was a 2x2 factorial trial, and so we randomized Albertans over the age of 65 who were low income and who were deemed at high cardiovascular risk based on their set of chronic conditions. And we randomized 5,000. So with Food RX, we had 600. This is a much bigger trial. And they were randomized to one of these 4 arms. So there were 2 interventions, so leading to the factorial design 4-arm trial. So the first one is copayment elimination. I'll tell you about that. So essentially free medications. The second one is a novel self-management education and support program. The third arm received both of the interventions, and the fourth arm received neither intervention. And we published both of these trials. So one showing the results of the self-management support intervention and the other showing the results of the copayment elimination intervention, both published in Circulation about 2 years ago, if you want to go find the results, but I'll tell you about the results anyway. The results, maybe before I go to the results, I'll tell you a little bit more about the interventions themselves. So the real government policy here is this copayment elimination arm. So ultimately what we said is that all of these people in Alberta currently, the public drug insurance plan covers everybody over the age of 65 without a premium. And I know in Quebec, you guys have premiums in your public program. So no premiums, but only a copayment, a 30% copayment for all the medications that you take. And when we look at cardiovascular patients, many of them are on 8 to 10 drugs at $30 a piece. Our previous work showed that many of these people face medication burdens of over $1,000 to $5,000 a year, even just with their co-payments. And so if you're making less than $50,000 a year and you're paying $3,000 out of pocket for your drugs, that has the potential to be a fairly significant financial disincentive. And so we worked with the government to say, could we give these people free medications? And can we test whether giving them free medications actually improves their adherence and improves their cardiovascular outcomes? And that's what the copayment elimination arm is. We've selected 15 classes of drugs, all the usual cardiovascular, diabetes, hypertension, AFib drugs, and those were all free. Copayments were eliminated for those drugs. The second intervention is a self-management program. This is a program that we designed in conjunction with an advertising company to help people learn more about their chronic conditions and engage more in the chronic disease management of these conditions. And so, again, similar to Food or X Out, it's more of a meso-level policy where the healthcare authority said essentially we would implement this at scale if it's proven successful. So we've got a government policy and a health system provider policy here that we're testing. And as I showed, the surprising results for me was that the giving people free medications did not change the outcome. And the outcome in this study was myocardial infarction, stroke, death, or ambulatory care sensitive hospitalization. So hospitalization for something that shouldn't have happened. So angina, diabetes, hypertension, those things that should be treated in the community. So things that ideally we wouldn't want to see. And when you give people free drugs, ultimately we see they have the same number and frequency of hospitalization, which was quite disappointing. When we tested the other intervention, the self-management intervention, we see that the curves do split. And particularly driven by this hospitalization intervention. And ultimately, the relative risk showed a 36% reduction in the number of hospitalizations for people who received this self-management support program compared to people who didn't. So contrary to what I expected at the beginning, I thought giving people free medications would improve outcomes and giving them this program would not. We actually saw the opposite. And I think this is a good example of why doing a policy trial is quite important, because sometimes the interventions we think are going to work ultimately don't. And so, we learned a number of things along the way with this trial. Again, recruitment is a consistent issue. And again, in this trial, we needed 5,000 people. And, if you ask at the very beginning, I kind of thought that recruiting people for this study would be like stealing candy from a baby is why I use this, that, we're giving people free medications and they're all low income people. So clearly everybody in the whole province is going to want to be part of this study. And that just was not the case. We launched the study in November of 2015, and by almost a year later, we'd only randomized 365 people, less than 10% of our sample. And it took us another several years to fully enroll the study. So we thought that we'd be fully enrolled within a year, and we were only 8% enrolled within the first year. So again, recruitment into these studies can be quite challenging. And we had to really use a broad recruitment approach for this study as well. So we recruited from doctors' offices, just like in the other one, and pharmacies. We also used Canada Post and radio advertisements and Facebook and other things. We did some outreach to pharmacies and local community organizations, and really a tremendous amount of work. And ultimately, we found were the most successful were actually using community pharmacies as well as recruiting from patient registries, that we could email or send letters to and say, hey, are you interested in maybe getting free drugs? Maybe you should sign up for this trial. So really a broad approach, but two really dominant strategies that helped us reach our recruitment target. This was an interesting paper that we published where we looked at recruitment over time, or people who contacted us about the study over time. And you can see that there were a few really big spikes in times where people contacted us, and those really corresponded to kind of press releases and media releases that happened. And we can see kind of spikes that happened with unpaid media, kind of when a TV station would pick up a story about the study and those types of things. And when we paid for media, we saw much less. There were various different things we tried over the course of this trial, and some worked and some didn't, is essentially what we learned here, is that recruiting for these trials really need a broad approach, and you need to think about your population and how to get the people into your study. The data collection for this study I'll skip this. But basically, I wanted to say that it resulted in a tremendous amount of paperwork. And I think many of us that run trials know that, when you're trying to collect patient-reported outcomes, either through REDCap or we also used iDataFax. This is how old this was, that we were collecting paper surveys and putting them through the fax to code the data, which all needed manual confirmation and somebody to go through and make sure that the data written by somebody was translated correctly into the digital data. Really resulted in mounds and stacks of paper that our research team had to sort through. We also had a lot of people that needed to do their surveys over the phone, right? We're dealing with low-income seniors, and many of them couldn't do the online portal and would struggle to get us their surveys back on paper as well. And so we actually would administer surveys over the telephone. And this is not actually a picture of our office, but it might as well be. We had an office with 3 or 4 research assistants who spent days and days on the phone collecting survey data from these 5,000 people. And sometimes it felt like that's Terry. That's a picture of Terry and her team back in the old days, trying to track down 5,000 people and get their surveys. The next big thing for any trial, I think, is thinking about attrition and thinking about how do we keep people, and especially in a trial like this where we were looking at outcomes longitudinally and wanted to follow people. I think a lot of trials that I see published in the big journals are, a 6-week or a 12-week trial or maybe a 6-month trial. But in order to test these pragmatic interventions, we often need a much longer follow-up period. And so we were following people for 3 years. And so, making sure that we could keep people in our study for the whole 3 years and keep them engaged was a challenge right from the beginning. We had to think about how do we keep people with us. And ultimately, I'm pleased to report that in our study of the number we randomized, we had a relatively low withdrawal rate. So, we had 13% in the co-payment arm who, if you're getting free drugs, most people aren't leaving the study. 20% dropped out from the control arm, and people who we were kind of in some ways harassing by sending them the self-management education were more likely to withdraw. So we had, a third of our participants withdrew from this arm, which is a threat to the validity of the study. If people are withdrawing and leaving the study, it makes it harder for us to know whether the interventions were working. But we overcame this by tapping into our administrative health data. And so I know you guys have a very similar data set in Quebec with all of the different data sources, but we use what's called the ACT-CTU or the ICDC network, we call it sometimes, but basically our provincial administrative data sources. So we had data on people's health insurance, and because they were all seniors, they all had their drugs paid essentially by the Alberta equivalent of RAMQ. So we had all drug information. We had all of the information about people's emergency department visits and hospital visits and physician claims, all within our data set. And people provided consent to link to these data sets. And they provided, when people withdrew, most of the time they didn't withdraw their consent for the linkage. They only withdrew their wish to be contacted by the study. And so most of the people didn't withdraw their consent for linkage. And so even though we had a number of people who withdrew and died throughout the course of the study, when we actually look at the number who we could analyze for the primary outcome, it was almost a full sample. And so really this helped our sample size tremendously for our primary outcome. So for some of the secondary outcomes, the surveys and all of that, we were maybe a little bit underpowered after the withdrawals. But for our primary outcome, we had essentially complete data collection, which is pretty rare for any randomized trial. The last piece I want to talk about here is about the ethicality of this study. And some people have asked us about, I don't know if you're familiar with this Jimmy Kimmel thing, but somebody showed me this years ago that after Halloween every year, Jimmy Kimmel does a segment where, the parents of young children who have been out trick-or-treating and getting candy tell their children that they ate all their candy. And they film the children and they all have a temper tantrum, and some cry and some yell and some scream and some are very sweet and understanding. But some people accused us in this trial of doing something similar, that we gave people free drugs for a time for 3 years, and then we took their free drugs away and they again had to go back to paying for their medications. And in the course of the peer review, and as we presented this trial, some people have questioned about whether it's ethical to do that. And, some people have raised the issue of, well, if you give people free medications, what if they go and buy a new house because they're no longer paying for that copayment? And now when they go back to paying for it again, they've overextended and they can no longer afford their living expenses. And so this is, something that was an interesting thought for policy trials, especially policy trials that try to address social disparities and whether it's actually ethical to give people resources and then take them away. And so, that's kind of the hypothesis, is that free medications leads to more disposable income. People upgrade their house or upgrade their car and can no longer afford those things. And we did a qualitative study about this to kind of figure out if that's the case. And so we interviewed people to ask them, what was it like for you going back to paying your copayment? How much of a burden was it for you after having free drugs for 3 years to now all of a sudden have to go and start paying for them again? And we did this qualitative study, and really, ultimately, most people said, yeah, it wasn't great. I wasn't super thrilled about having to go back to paying for my drugs, but I was aware that it was happening because they consented to it prospectively. We warned them ahead of time and sent them letters that it was coming. And people were quite grateful for having had those extra resources, even if it was in a time-limited way. So that was an interesting learning from this study that I hope will, assuage people's guilt and fears that giving people resources for a time-limited period might be undesirable or unethical in some way. I'm just going to skip over this. And basically, the point of this is kind of similar to the point of the FoodRx trial, that we studied the process also after the fact, and realized that there are a number of things that we needed to change in this MOXIE program, that the self-management program, similar to FoodRx, did need to change and adapt over time. And as we learned, things didn't work, and people complained about how frequently they were getting emails. We had to change the frequency of the emails, for example, and people liked the mailing frequency that they got, and they were initially getting monthly mailers, and we had to increase that to weekly. So there is this adaptive element of a policy trial that, as the previous question, ideally not making these changes halfway through a trial, but we're doing these implementation evaluations early on to make sure that the trial is meeting people's needs and is doing what we want it to do, so that we're not essentially wasting our resources testing an intervention that could have been improved with small tweaks. And the last piece is that these policy trials are intimately connected with knowledge translation and knowledge mobilization. And really, as I mentioned previously, a policy trial is really only a policy trial if there's a policy actor involved, and somebody who's willing to take the learnings from our study and implement it and put it in practice. And so we've been fortunate in our studies to work with people like Alberta Blue Cross and the pharmaceutical branch of the Provincial Ministry of Health, and Alberta Health Services, who are our policy actors, who are working with us and throughout the entire program of study to make sure that the evidence we're generating can lead to policy change. I'm going to turn it over to Terry to kind of give some big learnings that we've had about doing several of these policy trials now that are hopefully helpful to some of you, like Louise, who may be doing policy trials and not know you are, or maybe thinking about doing another policy trial, some of the things that we've learned as the policy trials unit. So take it away, Terry.
Yeah, for sure. So yeah, during these policy trials, we faced many challenges, as Dr. Campbell discussed, and we learned many lessons. And here's a few of them that I'll share with you. So first is the importance of the relationships with government and policymakers when doing a policy trial. Obviously, with Access, it was very successful because of our relationships that we had with Alberta Blue Cross, Alberta Health Services, and Alberta Health. And having these relationships from the beginning of the project and all the way through kept them engaged and invested in the project, and it helped strengthen our relationship and facilitate the knowledge translation, as Dr. Campbell mentioned. Also, recruitment is challenging. You've seen from these examples that recruitment was always tougher than we ever expected, and it took a lot of trial and error to find the correct recruitment methods. So for us, 2 lessons were that active recruitment methods, like engaging with the pharmacies, worked really well. We communicated continuously with them. We had monthly check-ins to answer questions. We made sure that we resupplied them with recruitment materials, and that kept the project fresh in their mind and helped them keep recruiting for us. Also using targeted recruitment. So tailoring the recruitment strategy for your specific population. So for the Food RX program, we were looking for people struggling with food insecurity. So the Calgary and Edmonton food banks really helped us recruit by putting flyers and our recruitment materials in their hampers that they handed out. The third is that health policy trials are complex. They're never easy. Implementing something like a healthy food intervention was much harder than we originally thought it would be. Large companies don't necessarily have the infrastructure to build these into their systems, and there are many constraints and complexities within technology that you have to really work around. So making sure you have those discussions early and have a contingency plan in place is really important. Also, the political environment, shifting priorities and policies with new governments can also affect the timelines, funding, and operations of your trial. Ethics and consent processes. There's a fine balance between the simplicity of and pragmatic design and legal and ethical compliance. So making sure that the real world setting like a lot of the times involves waivers of consent as well, and they're hard to navigate. So making sure that you start communications with your ethic board really early to work through those issues so your trials aren't delayed. Next slide. So these are just a list of some of the projects that we are currently working on or upcoming trials that will be happening soon. I'll just touch base. I won't go through them right now. I'll maybe mention one of them. So the BC Farmers Market nutrition coupon study is one of them that we hope to launch soon. And this is providing coupons to low-income households that can be redeemed for fruits, vegetables, meat, and other healthy foods at participating BC farmers markets. And this trial is testing the impact of providing different amounts of coupons to see if there's a minimum threshold required to see improvements in food insecurity and diet quality. Okay, next slide. So where are we going? What's next for the Health Policy Trials Unit? First is we're working on strategic growth and business development of our unit. We're doing this by trying to build awareness of the Health Policy Trials Unit, both internally and externally to the university, building capacity. We just hired a pharmacist to support some new projects. And developing a cost recovery method for health policy trials, support, for example, training of new coordinators in the policy space, working on partnerships with other organizations as well. The Health Policy Trials Unit was funded by ACT Canada, and now we're looking for ways to sustain the unit long term. Our third focus is, although we are still working with government and insurers and whatnot, we are also trying to work with more community organizations. So we are going to launch a event next month, actually, to build some partnerships with community organizations, help them understand what a policy or pragmatic trial might be and the barriers and challenges and how we can help them address some of the policies within their organizations. And fourthly, we're just trying to find our right home within the University of Calgary long term. Next slide. And what can the Health Policy Trials Unit offer you? We can offer some trial conceptualization and design. We can work with your organization to assess the gaps in your current policy. We can offer trial operational advice, so developing protocols with organizations or community partners and guiding trial design, support from some of our research staff or training research staff in the policy space. We can also provide analytics and knowledge mobilization and partner engagement. So really focusing on facilitating collaborations between key stakeholders and strengthening relationships with government and organizations as well. Next slide. So thank you all. If you want to learn more about the Health Policy Trials Unit, please visit our website at the QR code or contact us at the information below, or if you have any projects you'd like to discuss. Thanks so much.
Great. Thank you. so much to our speakers for a really enlightening talk. This is not something that we hear about that much at our institute. We might be doing it and not know about it, but it's nice to have a label for it. I'm going to open up the floor for questions. I'll begin. I was wondering if you have contacts in other provinces, if you're aware of other health policy type units like yourselves in Quebec or in other regions. I think we want to know I think something that might be interesting is for us to connect with our like provincial policy leaders to get the ideas flowing for types of trials like this. So I don't know if you're aware of any other groups that are doing something like you're doing.
Great question. I think we're aware of several other policy trial units that exist in other countries. So there's several in the US, there's some in Northern Ireland and the UK. I was just made aware of one in Australia, but I don't know of anyone else in Canada that has kind of a formal group working on policy trials. There's policy research groups, so there's several research entities that work in policy, and some of those researchers do policy trials. But in terms of a place where we can gather and bring people together, I'm not aware of any other ones that exist. And I think that's part of the vision of what we'd love for the ACT-funded health policy trials unit to become, is not just a University of Calgary entity, but a place where policy trial researchers can come and mingle and share ideas from across the country. So we'd be thrilled to partner and work with anybody at McGill or within Quebec who's working in this space and see how we can catalyze events together.
Yeah, that would be great, even if to make the government more aware, even like the federal government, and to have like just postings like we want to investigate this topic. Who's willing to take it on? So I think you guys are like the great start for that. Thank you.
Thanks, Amanda.
We have another question here in the room.
Thank you so much for a great presentation. So I noticed that a lot of the sponsors and stakeholders seem to also have, in addition to like wanting to promote patient care, some financial incentives for these policies by reducing costs on their end.
Mm-hmm.
Is that ever an issue or a hindrance when it comes to designing a trial in terms of, for example, identifying primary objectives?
Yeah, that's a really great question. I think you're absolutely right. And a lot of the people we work with, and we didn't even talk about some of the other entities that we're working with, like for-profit entities, right? So we partner closely with some pharmacies, for example, and their interest in working with us are maybe different than our interest in that they're looking for new business models and new ways to generate revenue. But I think that we need to capitalize on people's behavioral motivations. And if we can motivate people to want to improve patient outcomes because it's financially beneficial for their organization, then I think we can work together. We are always careful to make sure that the research is always driven from the scientific side. So, we're always aware of conflict of interest that could exist. And so we work with these people as collaborators, but the research is always driven from the university. We don't bring, those people onto our research teams as closely, and we disclose when they're involved. So, we've got ADMs and, CEOs and stuff on our publications, but they're not involved with the analysis and interpretation of the results. So there's always potential for conflict. You're absolutely right. But we try to mitigate that as best we can and also try to capitalize on the fact that there are different motivations for people to want to test policies. And that's one reason that we actually are looking for, is basically saying this could benefit you because X, Y, or Z. I don't know, Amity, if you want to build on that at all, some of the work that we've done.
I mean, I think in general, we're try to look for win-win-win situations where it can be, where like it might be a policy that could reduce costs for an insurer or the government, but it could also improve people's health. So those kinds of more high value kinds of interventions. So,
Yeah, that makes a lot of sense. And
hi, I have two questions. One is, do you have an example of a policy that you tested that has been actually implemented? And my second question is, government and policymakers, big group in my head. So do you have advice about, who are the best people to involve at those levels?
Yeah, really great questions. In terms of a policy trial that has been implemented, We don't have one of those yet. So kind of as Terry just showed on that last slide, we're doing about 10, we're kind of involved with 10 policy trials right now, but the only ones that are completed are the ones I presented. And so we've got essentially 3 trials, if you want to think of it that way. There's the Food RX, there's the self-management, and there's the co-payment elimination. And while the co-payment elimination, I would say, is the one that we were hoping was going to change policy, and the government was ready and willing to change policy because it was a null trial. They obviously didn't implement those policies, but what it enabled us to do is develop a relationship with that branch of the government and start talking about the issues that people in Alberta are facing with financial challenges. And they've engaged in a process, and that's still ongoing, kind of behind closed government doors, about renegotiating and reconsidering Alberta's approach to pharmaceutical coverage. And a lot of that was because of the work we started with the access trial. And even if obviously the access intervention itself is not implemented, and arguably it shouldn't be because it was a null result, we've been able to become kind of policy advisors and confidants for the government because of the established expertise that we've brought to the table. So that's kind of one example of, and we were just, our team was just in Edmonton 2 weeks ago meeting with government stakeholders, talking about the results of this trial and what some of the findings and implications could be. So I have hope that learnings from the trial will be implemented in the coming months. And then for the Food RX, the food side of that study I presented, obviously the results are not out yet, but I know that we are working kind of in the background with Alberta Blue Cross on their offerings. And if those results are successful, then we've got a plan in place to work with them to see how they're going to implement that within their benefit program. So I don't have a gold standard example yet, but I'm hopeful that we will soon. And I'll maybe let Amity answer your second question about kind of who within governments and stuff we found to be the best people to work with.
Yeah, I think it can depend. Like if you have like in this access trial, right? Like Braden Mans, the PI, had already had a relationship with the executive director of the pharmaceutical branch, and that kind of like helped even define and then implement the trial. So existing relationships can be a place to then build trials. In terms of like there was just an announcement in Alberta on Monday about a change to surgical payment models, and we thought, oh, that could be cool to study. What do we do now? So I'm like, I have a contact who works in like the Alberta Health System Transformation Division. So I asked her like, who's studying this? So she has a contact in a different unit and division, and she's going to reach out to them and see. So we're kind of going through a chain of like personal relationships to find connections. Another avenue of places we found contacts is through working with our university's government relations division team, like within the university. So you guys, I'm assuming, also would have that. So they could help either share, like we've developed research briefs about projects we've done before that we've then like used the government relations team to share with people they already have connections with. What are other I think those sort of like either existing relationships you have, finding other connections through people or then having the university make connections. Those are the main things that are coming to mind. We've also found, I think as Terry mentioned, we're like trying to work more with community groups. There's a community group in Calgary we've been doing a lot of work with, and they themselves are kind of like an organizer of organizations and do a lot of policy work and have a lot of connections, at different levels in Alberta. So just building those kinds of relationships are positive as well. I don't know, Dave, do you have any, or Terry, do you have any other things to add to this list?
Yeah, I think that's the right. I think I would also just add that, sometimes working from the top is not the right approach. Contacting the Minister of Health probably isn't going to go very far. And similar, working with some of you need somebody at a certain level of government organizations that have power to make decisions, but maybe are not as closely tied to political agendas. So working with senior bureaucrats we found to be quite helpful because they've got some autonomy, but they're also not as politically motivated. So kind of finding that sweet spot and finding who that right person is, I think is one of the challenges that we face. But we've been successful in some ways.
I'd say within the health system, it also matters like how things work or are changing within your health system. Like we've had very organized, like, one sort of regional health authority healthcare delivery system for many years, and then that's been changing. So I think as with many research projects, it's similar within the health system of having some sort of like system person in the system who's really a champion of the project, who's not just us, has been helpful. But then there's also issues of working with like the research unit within these kinds of with either the health system or the government, that can bring its own challenges as well.
Thanks very much. I give a call to Mark Hartney.
Yeah.
That'd
If you
be
can go to
great.
the top, if you go to right to the top, then that can help too. I don't think like going to the top is necessarily wrong, but it's if you know the right people, then you can start with that. But that is not to, I know we're over time, but like Dave mentioned, there are these other policy trial units in other countries. Like they often, a number of those are actually part of the government. Like so that I liked Amanda's idea. Like could we advocate for actually making an actual either federal or provincial level government research group that was more connected, or even if it's not within the group, like more at least arm's length that's like connected, because I think if that was a more established relationship, then maybe there would be those more opportunities to just to do these trials.
I know we're over time, well over time, but I'd just add to that. One of the challenges is that the government, as you mentioned, Amity, governments aren't always motivated by evidence, and they've got other motivations for the things they do, and sometimes they're not overly interested in evidence and doing a trial, right? And think about the access trial. Like if the government said we want to do this and we showed that it doesn't work, governments don't always like that either. So that's kind of why sometimes that the bureaucrat level, because politicians are so accountable to voters that sometimes the prospect of doing a trial and then being tied to something is challenging politically. So it's always just a place that we need to navigate, to try to portray the benefit the value that we bring without acknowledging that there are some risks politically. So thanks so much for having us. Feel free to reach out if anybody wants to chat more.
Thank you so much. It was really a pleasure hearing your talk today. So thank you everyone for joining us, and we wish you a great day.